Thank you. Well, good afternoon, good evening, everyone, wherever you happen to be in the world, and thank you for your continued interest in our teaching program. Today, we're very fortunate to have Dr. Nick Orsi, who is a colleague of mine through the Pathological Society. He's based over in Leeds, which is the other side of the Pennines from where I'm based. And just looking through his bio, I don't want to take too much of his time, but just to show you what such an eminent person Nick is, actually. So he started off in animal science at the University of Reading, which is close to where I was brought up. He then went on to do a PhD in York in animal biology, looking at mammalian reproduction. And then he went on to Leeds as a lecturer in Leeds. And whilst at Leeds, he then went on to do medicine. So he's really, a real card-carrying super scientist. Got all the credentials, and so it's probably appropriate that he's talking to us about endometrial pathology. He also does a lot of work in digital pathology, mathematical modeling, a really stellar kind of research output as well. And he's particularly interested in endometrial receptivity post-conception. So without further ado, we're very grateful for his time, a very busy person in Leeds. Over to you, Nick. Thank you.
Thank you very much, Richard, and hello and good evening or whatever to everybody. It's an absolute delight to be able to talk to you today. As Richard said, I think that's a sort of very flattering introduction, and I hope I'm going to be able at least to live up to some of the expectations. So, as Richard said, I am an academic pathologist. I'm based in Leeds, so we're very fortunate locally to have a centre which jointly features an academic and a clinical department. And so we work together very, very closely, and we have the benefit of actually being able to, on one hand, conduct blue sky research in our clinical labs, and then be able to translate and do clinical evaluations over in our clinical service at the same time. So it works very well. And one of the areas that's very close to my heart is endometrial cancer. It's a malignancy I've been working on and off probably for the best part of the last 20 years. And I thought I would give you a little bit of a whistle-stop tour of endometrial cancer and some common endometrial lesions. Whilst talking to Richard, I understand you're quite a diverse crew, and I sincerely hope I've managed to pitch this appropriately to, on one hand, provide a little bit of a refresher for the non-specialists as to what we're looking at in terms of endometrial cancer, maybe highlight, not necessarily as a continuous didactic teaching session, but with some examples that perhaps you can have a think about in terms of diagnoses, and then highlight some of the common diagnostic pitfalls that we commonly face in this sort of gynae reporting. And then I'd like to try and close really just by bringing in an aspect of research that really comes from the machine learning and digital pathology side. And I think that's quite important because that's going to be an increasing presence over the next sort of decade or so, particularly in developing economies as well, where I think the majority of the potential of this kind of technology can be brought to the fore. So without further ado, we're all very familiar with what normal endometrium looks like, and in our routine clinical reporting, you'll find that in the top left-hand panel image, we tend to refer to proliferative endometrium. So this is quite bland, it's boring. We're looking at these sort of nice little rounded glands. And at the other end of the spectrum, post-ovulation, we're faced with, in this instance, in the top right-hand panel, the secretory endometrium. So much more architecturally complex glands with secretions within their lumen. And then, of course, at the end of that secretory phase, we end up being faced with menstrual endometrium. So we get this breakdown of the endometrium mixed in with blood, and that's something that we commonly see in our curettings or pipelles and so on and so forth. In a large number of cases, of course, particularly in those that are associated with the development of endometrial cancer, we're faced with the middle right panel, which is atrophic endometrium. And it's very, very characteristic. We have this cuboidal epithelium covering the luminal surface and these cystically dilated glands, which are quite characteristic of what is now an inactive and non-stimulated endometrium. And then, of course, we've always got to be able to account for exogenous influences. And the example I've given here at the bottom, of course, is what we expect to see when we see decidualized endometrium. So enough about normal endometrium. What we're really interested in is when things start going wrong. And you'll all be familiar with endometrial hyperplasia. This is something that occurs in response to unopposed estrogen. And by that, I mean estrogen not counterbalanced by any progestin effect. And that's something that clinically we come across, particularly in anovulatory cycles, as we might see in PCOS, for instance. It does occur around about the perimenopause, but also increasingly now, certainly in the UK, that's something that features very prominently with the increased obesity pandemic. So this is peripherally produced estrogen that remains unopposed, and endometrial hyperplasia is now quite a common thing. There are exogenous causes, of course, estrogen therapy being one of them, and chiefly tamoxifen as well. And this is given for ER-positive breast cancers as part of premenopausal therapy. So the important distinction to make here is that there is a difference in terms of hyperplasia due to prolonged estrogen exposure and what we refer to as atypical endometrial hyperplasia, which is actually a pre-malignant lesion. This is the precursor lesion that eventually can evolve into endometrial cancer. And for those of you who are probably as long in the tooth as me, you will recall that originally we used to have these multiple categories about simple and complex hyperplasia and complex hyperplasia with atypia. The WHO have now simplified this simply as endometrial hyperplasia without atypia and atypical endometrial hyperplasia. And the synonym to that is endometrial enteroepithelial neoplasia. So what does it look like? Well, as we can see in the top panel here, this is a sort of low power view. And you can see you get this increased architectural complexity of these glands. This is an endometrium that looks quite busy, but actually at a high power view, it can look fairly bland. So this is an inactive high power view. You can see there's not very much going on in the middle right panel in this gland. The thing that tends to get quite confusing diagnostically is that in those cases that are still subject to estrogen stimulation, we can actually see mitotic figures, as we can see here in the middle left panel, and they start looking a little bit more worrisome. But this is still benign. This is not what is in the bottom panel, which is atypical endometrial hyperplasia. So what does that look like? Well, it's kind of hard to define, and this is something that can be particularly challenging in papel biopsies, for instance. But essentially what we're looking at is very much back-to-back glands, an increased gland to stroma ratio, and it's that architectural complexity that's combined with these large, round or elongated nuclei, but in particular a loss of nuclear polarity. So we get this sort of pseudostratification sometimes within the glands, and it looks very, very, very busy. Occasionally we can see nucleoli, sometimes we can see the odd mitosis, but that's not necessarily itself characteristic, a defining feature, should I say, that separates it from its benign counterpart. One thing to note is that if you're fortunate enough to work with a larger specimen, so here we're talking about a hysterectomy, is that the cytology of the hyperplasia with that atypia doesn't actually change at all between areas that have got crowded glands and not. And that's something that can give you a little bit of diagnostic comfort. Now, the next step, I suppose, is to try and be able to differentiate, and this is something that is very tricky again, particularly in small biopsy samples, is being able to differentiate between atypical endometrial hyperplasia and low-grade endometrioid carcinoma. And you can see, I mean, I think diagnostically here, it's fairly evident. On the left, we're looking at atypical endometrial hyperplasia, far more busy, and I apologize for the difference in magnification in the right-hand panel, where we're looking at endometrioid carcinoma. They do look similar. I think the sort of few diagnostic features that you've got to try and focus on, for those of you who aren't familiar with this, is really to try and hone in on the fact that there is very little intervening stroma between glands in invasive carcinoma. The architecture itself can be quite variable, so that's not really very helpful in all cases. But certainly if you can find some evidence of some desmoplastic type reaction, that's helpful. For higher grade cancers, if you have more atypia, again, that's helpful. But certainly if you can have some evidence of the presence of necrosis or macrophages, that's usually quite helpful. But those aren't always present. And these things are a diagnostic challenge, certainly with Papel biopsies or curettings. There is a huge amount of variability within samples, and it's very easy to get led down the garden path and think, well, I can see there's back-to-back glands and things look a bit dodgy, and you start zooming in all of a sudden on high power, and to drive yourself into thinking that you've got invasive carcinoma in what is otherwise atypical endometrial hyperplasia. And I think a good rule of thumb in that respect is to say, well, okay, things don't look quite right, but is it over an area that's about 2 millimeters or so? And that normally gives you that confidence to be able to make that call. If you're looking at 3 or 4 glands that just seem to be behaving a little bit oddly, actually that's probably not enough to go on and try and avoid overcalling it as invasive carcinoma. So endometrial cancer itself, and I'm going to be focusing just on carcinomas today because sarcomas are a completely different animal, and they probably need a session in their own right. But we have a variety of these, and chief amongst them is endometrial carcinoma. It's by far and away the commonest, accounts for over 3/4 of cases. And as I mentioned before, that arises from atypical endometrial hyperplasia. It's strongly associated, again, with unopposed estrogen exposure. And as we spoke about in the last slide, it has a glandular morphology. We have these back-to-back glands, but the architecture itself can be quite variable. And this can make things a little bit diagnostically challenging sometimes. One of the key things to mention is that these tumors obviously can have areas of squamous differentiation, and that's something to bear in mind, as I'll talk about in the next slide when we get down to grading these tumors. But essentially, these are capturing what used to be commonly referred to as type 1 cancers before the classification changed. We've got 3 different grades, and there are some fairly characteristic mutations for those of you who are interested. P10 being one of them, and this is a mutation that we see happening very early on in this carcinogenesis sequence, and P10 mutations actually occur very, very commonly, even in atypical endometrial hyperplasia. So we have that continuity of following mutations as the cancer progresses. Treatment, again, we're looking at hysterectomy and bilateral salpingo-oophorectomy, plus or minus lymph nodes and any other bits and pieces. And then it is very much down to the staging as to, and the molecular typing as to what the subsequent adjuvant therapy is. But it's worth saying that the prognosis for this tends to be better than for other types. So how do we grade these? Well, 3 grades, and essentially it's just falling either side of the 6 to 50% of solid growth. So as I mentioned before, a lot of these have what could appear as a sheet-like growth of cells, but actually it's just focal squamous differentiation. And that's something that we have to exclude in order to be able to avoid overcalling these in terms of grade. And then there is an additional feature, which is whether we have particularly marked nuclear atypia in what is otherwise an architectural pattern of grade 1 tumor that allows us to be able to raise that grade by an additional 1. One of the other more common lesions, and this is one that we need to be very wary of, is serous carcinoma. So this arises in the endometrium, but it has a sister lesion, as you'll be familiar, in the ovary as well. Far less common. These fall under the banner of what used to be referred to as type 2 carcinomas originally, so estrogen independent, and they are far more aggressive, far more nasty, and they arise from a completely different precursor lesion, in this case endometrial intraepithelial carcinoma. And we know, at least through looking at a very large series of these, that they can be associated with BRCA1 and BRCA2 mutations, and certainly have an association with Lynch syndrome, which we'll go on to talk about in a minute. Structurally, or architecturally, I should say, they tend to have a papillary morphology, but don't be fooled, they can be quite variable. Tumor-wise, well, they're very aggressive, they tend to spread, and as a result, prognosis tends to be quite poor and recurrence rates tend to be quite high. Mutation spectrum-wise, P53 mutations are actually so common in the majority of these that we can use them as a hallmark to be able to differentiate them from other morphological subtypes. So that's something that's handy to know if you're not quite certain diagnostically where you sit. Treatment-wise, again, we're looking at surgery followed by various indications in terms of adjuvant therapy, in part stage related. So I realize maybe sort of just delivering didactic teaching isn't particularly helpful. I've suddenly realized that on my screen I can't see what's in the chat, but I was going to put to you, okay, what do you think the diagnosis is in this case? So we're looking in the top panel at a lesion that clearly has irregular sort of glandular type morphology. It's got what appears to be a fairly flat epithelium, but the striking element within that is that it's got a high degree of nuclear atypia. And in itself, that is enough to make you feel a little bit uneasy. This one has had an ER and a P53 done on it, both of which actually feature there. And I'll just give you a minute to think about what this could be then lesion-wise diagnostically. Unfortunately, I can't see your feedback, so I can't make this interactive.
So I can see the chat. Ava, I'm not sure. I don't know if you're able to facilitate the chat for Nick, but otherwise I can certainly read out the chat that comes back. Okay. So we've got one answer: G3 endometrial carcinoma.
Mm-hmm. And that is typically where you would go with this, because it has a glandular type morphology and you think, yeah, that's probably what it is, and this high degree of nuclear atypia is probably enough. The key element here that should make you feel a little bit uneasy about that is that it's P53 mutant, right? We don't have an expression profile for P53 here. It's P53 null. And apologies. The take-home message here is that it is also ER negative, right? We can see these little islands that aren't staining either. And the idea of having these high-grade nuclei should always try and make you think whether this could be a serous lesion, but that actually has an abnormal morphology. And there is a glandular type of serous endometrial carcinoma, which this is. In much the same way as there can be a papillary or more papillary structurally organized type of endometrial cancer. Okay, so moving on to clear cell carcinoma, which is the next item on the menu. These are actually quite rare. I think we only get about probably fewer than 10 per year at Leeds. These again fall under the banner of the type 2, or what used to be formerly categorized as type 2 lesions, not linked to estrogen exposure, and historically actually linked to exposure to diethylstilbestrol. Architecturally, again, they can be quite variable. Really, the take-home message here is that these cells are very distinctive insofar as they've got cleared cytoplasm due to a lot of glycogen deposition and these hobnail features. And I think once you see them, particularly on low power, it's very, very striking how different they look to the other morphological subtypes. Unfortunately, they tend to be quite aggressive. They're prone to early spread. They also tend to carry P53 mutations, but they've also got mutations in PIK3CA and ARID1A. So This is sort of a profile that is shared to a degree with some of the gastric carcinomas. And again, treatment is surgery followed by chemotherapy or radiation. But being such aggressive tumors, they carry a very poor prognosis. And my favorite in the bunch are these. These are carcinosarcomas, and I apologize again for the quality of the image in the top panel there. But essentially, these are rare. They're biphasic tumors. And the take-home message here is that although it is a tumor that is composed of a carcinomatous element and a sarcomatous element, their origin is entirely epithelial. So here we have a high-grade carcinoma that has undergone mesenchymal, epithelial mesenchymal transition in one of its subclones, and so you end up having two adjacent tumors, right? This is not a sarcoma that's a collision tumor with a carcinoma. It's a carcinoma that has given rise to a sarcoma or a sarcoma-like element within it. You tend to get, as you can see in the middle panel, areas of sarcoma which can show focal differentiation. Chondroid is quite common. You can have rhabdomyocytic. You can have others. I know as pathologists, it becomes quite easy just to try and obsess and try and characterize these and write them in the reports. It's super interesting, of course, but based on some of the case series that have been studied, actually the differentiation of the sarcomatous element really doesn't carry any prognostic significance at all. These are, regardless of anything else, quite aggressive tumors with a very poor prognosis. The one thing to bear in mind with those is that they need to be differentiated from endometrial sarcomas, and it is not unusual sometimes for these to, simply through sampling, to actually deliver entire blocks that could be composed entirely of the sarcomatous element, and the carcinomatous element may just be tucked away in the last slide in the panel that you've looked at. It's important to make that distinction because these things are managed and staged differently to sarcomas. So always try and make sure that you can differentiate them from true sarcomas or adenosarcomas, which obviously only contain benign glandular elements. So here's another one, and again, sort of seeing it on the screen at the moment, the images aren't entirely clear, but we've got a lesion that is composed of spindle cells, quite cellular. We've got some glandular elements, but not really very many, and not particularly high grade. What would you be thinking of when looking at these? Are we looking at a carcinosarcoma? Are we looking at a sarcoma? Or are we looking at a carcinoma itself? And again, I'll give you a couple of minutes to think about this.
Okay, so Schuster says carcinosarcoma.
Mm-hmm. And intuitively, that's what you'd say, right? There is clearly a mesenchymal element to it, as well as a carcinomatous element to it. The key take-home message here is that if you look at those spindle cells, there's nothing about them that is screaming that they are high grades. If this were a true carcinosarcoma, you would be expecting some fairly convincing levels of nuclear atypia within the sarcomatous element. So this again, and I'm sorry I keep throwing red herrings at you, but it's just to try and highlight the point that carcinosarcomas are invariably really convincingly high grade. This is not. This is an endometrioid carcinoma. It just is one with a spindle cell variant, which has just decided to go on its own merry way. And what you would do here again, just to be able to differentiate it from carcinosarcoma, the grade alone is sufficient. But again, if you were trying to separate a carcinosarcoma from a true sarcoma, you'd again try and run a pancytokeratin, and that staining pattern tends to be retained within the mesenchymal element as well. And again, as I mentioned a little bit earlier, It's important because sarcomas are staged differently, managed differently, and obviously carry an even worse prognosis. I just wanted to touch on some of the rarer subtypes. These are things that, you know, as rare as hen's teeth, we see them so infrequently. Mucinous carcinomas in the top panel, and you can see that essentially you have large areas within these tumors that show mucinous differentiation. So this isn't something that you should think diagnostically of calling for focal differentiation in what is otherwise a fairly convincing run-of-the-mill endometrioid carcinoma. You need a significant proportion of that tumor, over 50%, in order to be able to make that call. There's two different flavors to those. There's a rarer intestinal type, which has a poorer prognosis, and a much more common endocervical-like subtype, which seems to do a little bit better. But again, because they are so uncommon, there's a limited amount of data on how these do. Undifferentiated carcinomas, so I think your eye will be drawn to the middle panel there. We're looking at these solid sheets of cells with high nuclear to cytoplasmic ratio. They're usually very mitotically active. They can show areas of necrosis as well. And really, they don't look like much. The differentiation really isn't very convincing. They're very aggressive and they carry a poor prognosis. And it is that particular feature within those that can sometimes coexist with a much more readily identifiable morphological subtype of low grade. And in those cases, we tend to refer to those as dedifferentiated carcinomas. But again, these are vanishingly rare, and we hardly ever see them. Just to carry on for the stamp collecting for rare lesions, there are neuroendocrine tumors as well within the endometrium, very uncommon. They can be low grade or high grade, and in the latter case, they can be small or large cell. And very much like we see in prostate sometimes, that sort of neuroendocrine element is often in association with a much more common morphological subtype rather than being a pure lesion of neuroendocrine type. If you're in any doubt as to what these might be, or just think, well, am I looking at a dedifferentiated carcinoma here? In reality, you can just throw some neuroendocrine markers, and these typically tend to be synaptophysic and chromogranin positive. And I just want to finish off in terms of morphological subtypes by looking at mixed carcinomas. So these are, again, carcinomas that have two completely different morphological subtypes that coexist. You can have an endometrioid and a serous, as we can see here, or we can have even further subtypes. And that's quite important because from a reporting perspective, we must include all the morphological subtypes that we can identify within those lesions. And certainly in instances where the non-dominant type, imagine it was serous on a background of endometrioid, if it is more than 5% of the total tumor, then actually that has prognostic implications because these tumors tend to behave a lot more aggressively. Okay, when I spoke to Richards, we were talking about immunohistochemistry, and it sort of struck me that some of you will have access to this very readily. Some of you may be more limited or challenged into sort of budgets that you can spend on immunohistochemistry. And I know certainly even here in the lab, we tend to get the Spanish Inquisition if we want to buy too many antibodies. So it seems sensible to say, well, okay, if you're going to spend your money on antibodies, which are the ones that would actually be quite handy to work with for endometrial pathology? And I think, I mean, this is by no means meant to be an exhaustive list. It's just meant to be something that probably will come in useful and will be a good investment. ER and PR, which are very good for picking out endometrioid carcinoma, certainly if it's low grade. As we touched on before, P53, we tend to get an aberrant staining pattern in the serous carcinoma, and you can use P16 to back that up if you wish, but P53 is normally sufficient. I've put Vimentin, and that's not something that we use to differentiate between endometrial carcinomas. It's more to try and identify how these differ in terms of identifying them from what are in fact primary cervical lesions or ovarian lesions. And then finally, napsin A, and that's normally a very clear marker of clear cell carcinoma. HFN1 beta is also, but in fact it's not as robust. And if you had to spend your money on something, napsin A would probably be a good place to go. Okay, I spoke a little bit earlier about having moved away from the traditional way of looking at endometrial cancers, either as type 1, estrogen dependent, type 2, largely estrogen dependent, into something that is now much more informative and certainly prognostically more useful. And that's the most up-to-date molecular classification. And that currently recognizes 4 particular subtypes. The first one of these is polymerase epsilon mutant. And these are lesions that actually can look pretty nasty. You can be looking at a grade 3 endometrioid carcinoma, but actually the fact that they're polymutant gives them a reasonably favorable prognosis. So much so that actually sometimes, you should be thinking about de-escalating or treatment, or in fact, considering that there is no need for adjuvant therapy. Mismatch repair deficient is something that we now in Leeds do routinely on every single endometrial cancer. We do it by immunohistochemistry, and you're looking at the expression profile for MLH1 and PMS2 and MSH2 and 6 as pairs of DNA repair proteins. And these cases tend to carry an intermediate prognosis, and they could indicate Lynch syndrome. I'll go on to describe that in a minute. But because these have got defective DNA repair pathways, in reality, they carry a fairly substantial neoantigen load, and actually can now be informative and be able to say, okay, perhaps we can start considering this as an eligibility criterion for patients to receive immunotherapy, which is increasingly gaining momentum. The third category are the P53 abnormal. So generally when we find that we have a mismatch repair proficient tumors, they're tested for P53, and any abnormal expression is considered to be P53 abnormal. I'll show you some examples of that in just a second. And unfortunately, if you remember, these tend to align to these morphological subtypes, the serous, the clear cells, and so on and so forth, that carry a very poor prognosis. So again, that's useful in terms of being able to decide whether these patients should receive more intensive systemic therapy. But in reality, the majority of cases don't really fall into these 3 categories at all. They all get lumped together in no specific molecular profile. And this is quite a large group. It's a mixed bag, and I expect probably over the next 10 years or so, that's going to get sort of broken down into further subgroups, and they tend to carry an intermediate prognosis, and they tend to usually capture the vast majority of the low-grade endometrioid carcinomas. The reason why a lot of this testing has been useful is because P53 and poly profiles actually now fit into the FIGO 2023 staging system. And I'll go on to describe that in a minute, because there have been some difficulties with adopting that in a rational way across different centers. But the molecular testing is also useful because it allows you to make these risk-based assessments on the histology. So as I mentioned before, polymutants in what would otherwise be a high-grade endometrioid tumor downgrades that risk, and similarly, P53 will increase it accordingly. So mismatch repair testing, well, it's reflex testing that kicks off after your diagnosis of carcinoma. So as I said, we do it all in-house in Leeds by IHC, so looking at MLH1, PMS2 as one pair, and MSH2 and MSH6 as another pair. In instances where we see loss of MLH1 and PMS2, then the key element here is to see whether this is a sporadic event. So is it due to promoter hypermethylation? And in these cases, we'll send these samples off for pyrosequencing in order to be able to determine whether we've got hypermethylation of the promoter or not, and then move on down the Lynch syndrome germline testing pathway. In cases where we've got MSH2 and MSH6 loss, or in fact just isolated PMS2 loss, we tend to normally go directly to germline genetic testing, as these tend to be hallmarks of Lynch syndrome. But by far and away, MSH2 and MSH6 loss is not common. To show you, for those of you who may be less familiar with this, how very convincing the retained staining pattern is, the top image you can see on the right hand side, this is MLH1. We've got fairly strong staining of this particular carcinoma. On the left hand of the image, there's been there is clonal heterogeneity within that tumor, and it is mismatch repair deficient on the left and mismatch repair proficient on the right. The PMS2, which is the other one of the pair, same lesion, and you'll see that that staining pattern broadly mirrors what we see for MLH1. So it's not unusual to have these clonal, these subclonal differences within individual tumors, and sometimes it is very much down to chance as to which block you select to have your IHC testing on. The panel at the bottom of this particular slide is just showing focal MSH6 loss. And again, it's always very difficult to know what to do in these instances. And there are several issues to note, I guess, from my perspective. The first one is know your assay. And that's really to get an appreciation of what the staining pattern you expect to see is. And secondly, at what point is subclonality of any relevance? And I love when people come and give me a number and they say, hey, do you know what? We're going to give you a completely arbitrary cutoff of 10%, but that's what we think makes sense to say, okay, above 10% of your lesion shows that you've got subclonality. That's got a clinical implication. Great. You can include that within your report. If it's less than 10%, well, it's probably of a lesser significance. And I think that the data supporting that, I'm sure, aren't particularly strong, but it's a reference point that we tend to use. So when I said know your assay, and that's simply because there are a number of potentially different antibodies that you can use for mismatch repair testing. And certainly what we've seen with the here in the middle two far right panels, this is a lesion that should be MSH2 and MSH6 deficient, and it's very obvious on the dacoadjuvant antibody, but in fact we've got this much more widespread dot-like positivity using the Ventana Roche platform. And that, if you're familiar with this, that's great. If you're working with samples that either get referred in or working across different centers, it can be quite misleading. So although it's fairly convincing, just bear in mind that you should be aware of the idiosyncrasies of the different antibodies that you could be exposed to. Now, if you remember, for those who are found not to have MLH1 promoter hypermethylation, then they will go for germline testing. And the key thing here is to try and see whether the mutation that you've identified within the tumor is actually germline rather than somatic. And patients will be invited in, they will give a blood sample, and they will be tested to see whether they've got a pathogenic gene variant present in which reflects the mutational, the mismatch repair deficiency that was identified within the tumor. The reason why that's done is, on one hand, it benefits the, apologies for that. Oops. It benefits the patients themselves, because obviously if you have Lynch syndrome, you're at higher risk of getting both colorectal and endometrial cancer. But also it enables to implement family cascade testing. So here you're trying to identify relatives who could be carriers of the same germline mutation, and you can go and offer them early screening and preventative strategies and surveillance. So I mentioned earlier that there are different p53 staining patterns. In the top left-hand image, we've got what is effectively wild-type staining. So you can see it's fairly strong, convincing staining, nuclear staining within this particular tumor, but it's patchy, right? It's not all cells are positive, and that's normally what we expect to see. In panel A, that's an aberrant profile. So this is mutant overexpression, and you can see that every single cell within the lesion at this point is positive. There are some areas with that aren't staining in between, and of course that's the intervening stroma in between. In panel B, and that's in the top far right, you can see that this is referred to as null mutant. So this is a mutation that has resulted in a complete loss of p53 expression, and that again is considered as being p53 abnormal. And then just to increase the variety of flavors that we work with, we end up with panel C in the bottom left, and that's where we get cytoplasmic expression as well. So all three of those are considered aberrant. And then of course we have sometimes what appears in panel D, and I'm hoping by now one of you can tell me what you think is happening here. We've got one area of the lesion where we've got what appears to be mutant overexpression, and in the other one we've got what appears to be null mutant. Any thoughts?
Are any thoughts from the audience? Oh, okay. Yeah, Ursin says dedifferentiation.
Yeah. So absolutely, and here, you know, we're looking at a different clone essentially within this particular lesion. So it's gone down different pathway, it's done its own thing, and has lost expression focally. I know the example I've given you in D, I've just picked it because there's a huge contrast between them. You've got one which is, you know, mutant overexpression, the other which is null mutant. In reality, in the vast majority of cases, the remainder of the tumor tends to show wild type expression. So this is what we see in the top left panel. Unfortunately, this can have implications, elements of subclonality again, particularly if you're working with identifying, so profiling your mutations using sequencing, because you're going to be mushing up your tumor and providing components from both. Unfortunately, how we really determine that isn't very well known because it's understudied as a phenomenon. It hasn't been very well defined. But again, someone's had the bright idea of going back and saying, do you know what? We're still going to apply that 10% cutoff to define subclonality. Absolutely fine by me. I can hang my hat on that. Okay, so talking about p53, imagine this is a specimen that you received. You've got your low power view on the top, so something which, you know, has got fairly prominent papillary architecture, and you've got your low power view on top, and you've got your high power view at the bottom, and you're thinking, okay, what kind of endometrial carcinoma am I looking at here? And the IHC that you run alongside shows that it's got a wild type p53 pattern. What are you guys thinking this might be?
Any ideas from everyone? I must admit, as a heme path person, I'm stumped. So we need some help here. Ursin asks for P16 status.
It's a very good shout. We haven't got it, but yes, it is a good shout. Morphologically, I guess, is where I'm going with this. What would you be inclined to call it?
Ersin, it looks like it's over to you. Serous.
Absolutely. So you would go for Cirrus. I mean, cytologically, architecturally, it's telling you Cirrus. And it is very easy. And I've fallen into that trap myself as well. You'll throw a P53 at it, it'll come back with a wild type pattern. And you go, oh, this must just be one of these rather weird, slightly more papillary type of endometrioid carcinomas. And it's not. Remember that there are a proportion, about 5 to 10% of serous carcinomas that do actually show P53 wild type expression, at least in terms of immunohistochemistry. And that's simply because the mutation profiles that they've got can affect the staining pattern. So where I'm going with this really is just think that the morphology, be confident in your morphological assessment. The immunohistochemistry really here is to support your morphological diagnosis, not to replace it. And so if you're in any doubt, try and go back, look at the H&E again, check whether the lab's done the IHC properly. We've got, hits and misses sometimes in the lab here, and potentially look back at how that particular specimen was fixed. I know we had an episode probably going back about 6-7 years ago where we had a run where I have absolutely no idea why formalin wasn't put in the saline, and the fixation in the specimens was terrible. It was absolutely impossible to make any kind of assessment on immunohistochemistry. Okay, I just want to follow on just with a very quick note on practical reporting. So again, what are the things that matter? Well, we look at morphological subtype. We've mentioned grade. What used to be very important was the depth of myometrial invasion, whether the cervix was involved. As with other lesions, we tend to concentrate on whether there's lymphovascular space invasion. And of course, serosal involvement, metastasis to lymph nodes, and so on and so forth, and whether the margins are positive. And where I'm going with this is the original staging that we all loved so dearly, which was FIGO 2009. And the beauty of this is that it was very simple, very straightforward, very easy to memorize. And of course, it was entirely based on the anatomy. What we have struggled to move on to is the new 2023 FIGO staging. And there are both benefits and drawbacks to this. I suppose the biggest difference from the 2009 iteration is that this now includes non-anatomical parameters. And you can see in the top right-hand panel here, we're interested in what tumor type it is. We're interested in the grade. We want to know if there's lymphovascular space invasion. And of course, we want to know the molecular subtype of it as well. So it's caused a radical change to the way we stage these tumors. And what it has become now really is a risk stratification system. It's not really the anatomy-based traditional staging system that we were used to in the 2009 iteration. So of course, there's no reason to move to this if it has no value, and it does. I'm not taking away from that. And prognostically, it is very, very, very helpful. The disadvantage is that it is extremely unwieldy. I will be honest, have struggled to have a fairly concerted adoption to implement this particularly well. And that in part is because at the time of reporting, we do not necessarily have the entirety of the molecular profile. So we tend to outsource our poly testing. The turnaround times can be as long as 6 weeks sometimes. And of course, it is a problem with this because P53 abnormal or polymutation in stages 1 and 2 can actually either upstage or downstage the particular lesion, as you can see in the bottom left-hand panel. So it has been a little bit of a struggle to try and adopt this without any difficulty. And for me, this also makes it a little bit more challenging for people who may be working in parts of the world where actually access to molecular testing or immunohistochemistry may be rather more limited, or whether the turnaround times for those actually are even longer than the ones that that we're having to deal with. So I just wanted to follow on, and as we sort of head towards closure, just to highlight some common diagnostic pitfalls that we have. And I think we touched on at the beginning about the possibility of missing serous carcinoma. It is really easy if you're working with small tumors or curettings or a particularly inadequate or stuff that is borderline inadequate papal biopsy, of being unable to actually acknowledge that serous carcinoma is present. And you can say, okay, it looks glandular, or it's not particularly papillary, or the tissue is so damaged that it is very hard to make an assessment. And the risk here is that you could potentially confuse high-grade endometrioid with serous and vice versa, because they can have overlapping features, certainly in terms of the nuclear atypia. And here, remember, you can use IHC as your support. I know I gave you the perfect example of where P53 is completely unhelpful. Generally, in the majority of cases, it is. So P53 and ER are normally quite good. And it's important to make that distinction, because missing serous carcinoma and calling it endometrioid will lead to catastrophic undertreatment of the patient. So really, if anywhere there's high-grade nuclei, you're a little bit uneasy, consider using immunohistochemistry. Something that certainly I and others will have been guilty of is overdiagnosing carcinoma in small specimens. So this is calling what is atypical endometrial hyperplasia as invasive carcinoma. You think, well, is it the end of the world? The management of these patients tends to be that they're going to have a hysterectomy anyway. And sure, maybe that's not the end of the world. It will be a problem for those younger fertile women who haven't yet finished completing their family, who may have been denied the option at that point of very short-term management with progestins, and see whether they have the option of carrying a pregnancy to term before their hysterectomy. So again, try and see whether you can establish invasion. So look for desmoplasia, look for areas of necrosis if at all possible. I mentioned before, there can be problems with miscalling carcinosarcoma as true sarcoma, and this is simply because the limited sampling you may have may not actually contain the carcinomatous element. Try and do a pancytokeratin. That normally helps if you're in any doubt. Misinterpreting P53, also very common. Sometimes you can get patchy strong staining, and you may consider it abnormal simply because you go, oh, maybe there's an area that looks really, really focal where all the cells are actually, all the nuclei are actually positive. Look at the lesion in its entirety and look at whether this is just a focal thing that is happening that is probably just, less than 10%, in which case it doesn't really have any prognostic significance. The take-home message really is P53 staining, it's normally clearly normal or abnormal, provided you have enough material to work with. If you're in any doubt, just ask the lab to repeat it. Overgrading endometrioid carcinoma, easy to do. I've certainly done it in the past, and that's usually due to failing to discount these areas of squamous differentiation when you're assessing your solid growth pattern, and miscalling LVSI. And lymphovascular space invasion now is one of the criteria that feeds into FIGO 2023. We all have faced this problem of confusing it with retraction artifact. Again, as much as possible, given that it now affects staging, try and look for endothelium. Throw a CD34 at it if you want. Underreporting mixed tumors, I touched on that earlier. Again, report all subtypes and their relative proportions, because that can increase the aggressiveness of these particular tumors. Certainly even a 5 to 10% serous element in a mixed tumor makes it a high-risk tumor. And don't over-rely on immunohistochemistry, okay? Immunohistochemistry is great as a technique, but if you have issues with tissue processing, with the way the labs are conducted, or you may not have had your autostainer serviced, and so on and so forth. That can reduce the reliability. The other thing to bear in mind, of course, is that none of these cancers have read any pathology textbooks, and you will always come across that one particular case where it just has an aberrant staining pattern simply because it's just a statistic. So remember, IHC supports the morphology, it doesn't replace it. And I just want to close just by mentioning artificial intelligence. And again, forgive me if you've heard this from other speakers before. The only reason I've chosen to mention it is this is a large proportion of my academic work, which is trying to develop algorithms. And this is largely because Leeds has been a fully digitized centre now for the best part of 7 years. So we can do all reporting digitally on computer screen. It's quite handy, particularly if you're working on low power. Not everyone likes it, but essentially we have huge amounts, huge repositories of digital images of a range of tumors. And that's very useful because these compendia of images can now be used to develop particular algorithms. So these are machine learning algorithms, which are going to be able to try and help us fulfill some of our diagnostic tasks. And that's particularly useful in places like the UK where there aren't enough pathologists, where maybe we could shed some of our workload or put some of the more mundane stuff in the hands of algorithms. So what do these things promise they can do for us? Well, they can say, we can help you identify morphological subtype. Maybe we can give you a second opinion on grade. Perhaps we can even, detect myometrial invasion or lymphovascular space invasion. But the way these algorithms work is by extracting information from these digital images. And these are not things that we may be aware of as pathologists. The features that are extracted by these computer algorithms may be very different to what we as humans recognize as being a diagnostic feature in its own right. But what they promise to do is to improve our diagnostic accuracy. They can be reproducible. So I know I'll be very different on a Monday morning and a Friday afternoon. An algorithm will be as good or as bad at those particular times. The computers simply don't get tired. But I don't think there is a place for these algorithms either now or in the future in really replacing pathologists. And I think that was a concern when I started working in this area, that it was all about replacing pathologists. It's not. These algorithms are at best meant to be adjunct tools who help with diagnostic practice. But I find them fascinating, and the reason for that is that I can see they would be of great value, particularly in resource poor settings, because you don't need a lab to do immunohistochemistry if you've got an algorithm that can say, identify the molecular subtype of a breast cancer. Is it ER positive, PR positive, HER2 negative, on the basis of an image analysis? Well, all you need is a scanner and a power supply and an internet connection. You don't need a lab to be able to do your testing. So it may actually be that these things can come to the fore, one, in reducing diagnostic costs, but also in actually improving accessibility to personalized medicine in resource poor settings. And to do this, I just want to close on an example, and this is something that my team has done in partnership with an industrial partner called Diagnexia. And this was really to try and develop MSI testing. So again, colorectal cancers, much like endometrial cancers, we're interested in their mismatch repair status. The testing that we do at Leeds is the MSI Plus. So it's a PCR-based assay. We've moved away from immunohistochemistry. The trouble is we ship it out to be done somewhere else, and the turnaround times can be, upwards of 2 weeks. Is there a way where we can actually accelerate that diagnostic testing? So we developed this algorithm on the several thousand colorectal cancers of known MSI or mismatch repair status, and then said, okay, now that we get an impression of how robustly it manages to extract the MSI or mismatch repair status on the basis of the images alone, we're going to give it images it has never seen before and see how it works. And I'll show you the results in a minute, but essentially this is a process that is fully automated. We get the results within, usually for biopsies, in under a minute, perhaps maybe 3 to 5 minutes for a block from a resection specimen, but nothing like the turnaround times that we do. The way these computer-based platforms work is deceptively simple, and that's highlighted in panel B, where you input your whole slide image. You've got a pre-processing part to this pipeline, which essentially removes all the blank space. You're just concentrating on the tissue. That gets broken up into an array of tiles. They get fed into your deep learning model, so convolutional neural network effectively. And then it feeds through this and comes out with, through the classifier, and here we have a dichotomous classifier. It's either stable or unstable, and we've got our biomarker result. So what does that look like in real life? Well, these are 3,500 or so cases that we collected across England, Wales, and Northern Ireland. And you can see the overall agreement with the standard routine standard of care testing, in fact, is around about 94%. So this is kind of at the level where we expect to see concordance across orthogonal measures for the same point of analysis. But if you look at the positive percent agreement, we're looking at 93%, right? This is a measure which is pretty much specificity. Sensitivity. We've got a negative percent agreement, again, 94%, which is our specificity. And the C statistic in the very last box here is effectively a measure of the area under the curve. So the closer to 1 that is, the more accurate it is. So this is something that we feel can perform clinically. And we've just started a clinical evaluation in our department here to see whether actually this could potentially work as a replacement to the MSI plus testing. So the jury's out there as to whether it works or not. The one thing that we're particularly interested in is the test replacement rate. So this is this 86.55%. And the reason for that is you can have an algorithm that is very good at getting things accurately, but it only works for 10% of your tests. Clinically, that is of absolutely no use. So we need something that is able to give us a result very quickly, and then says, okay, for X amount of cases, in this case about 13.5%, I don't feel confident that I can give you an accurate result, and that will have to go through the routine testing pathway. And that's fine. But this has immediate benefits in terms of faster turnaround time, certainly for those cases where you get an immediate result, and a reduction in cost as well. The one thing that makes pathologists very, very, very nervous about this kind of technology is that a lot of them that have been developed to date have been black box. So you're feeding these images into algorithms. The algorithms are saying, yes, this is the particular answer, and you have absolutely no idea why. And so it is about getting a handle on explainability. And I promise this is my last slide. I've just looked at time. Apologies for that. And the module that we have actually back projects onto the original image. And you can see in the heat map here in panel B, there are areas of different color, and those correspond to the tumors that we can see in row A at the top. The areas highlighted in blue are where the algorithm hasn't really paid a huge amount of attention at all. So it's kind of gone, oh yeah, this is fat, I'm not really interested in it, and it's moved on. The areas where it's paid a huge amount of attention and gone back to look at it in more detail are the ones that appear in red. As you'll see, these overlap very nicely with those areas where there is fairly self-evident carcinoma. So I just want to finish by saying just a few take-home messages. Again, we touched on the common diagnostic pitfalls. Just be aware of them, avoid as much as you can overcalling or undercalling lesions. I know it's self-evident. I've made that mistake, and I'm sure I'll carry on making it. Avoid being overly reliant on immunohistochemistry. So morphology really is still king. I firmly believe that, and that you can still practice very good pathology even if you don't have access to molecular testing. And sometimes that can actually be your enemy if you rely on it a little bit too much. I would expect certainly over the next 10 years, the testing regime complexity to increase quite markedly compared to what we have at the moment. So again, those no specific molecular types of endometrial cancers will probably get subdivided further. It's going to be even more complicated. And I expect we'll get a different iteration of FIGO 2023 in the future, which will be even more complex to work. But regardless of that, I think keep your eye on the horizon and I suppose prepare for maybe artificial intelligence actually to have a growing presence, certainly in the diagnostic space, but also in prognostication, predicting response to therapy, and helping risk stratify patients to different treatments. So again, I'm sorry I've gone slightly over. Many thanks for your attention. I'm happy to take any questions.
Thank you very much, Nick. That was absolutely excellent. Really good mix of histology, molecular classification, the use of it, and also artificial intelligence. Are there any questions from the audience, please? Maybe people put in the chat the different locations they're in so that we can share that with Nick as well. I suppose my question is, if these algorithms can detect MSI changes, I suppose could they check pole changes as well? So could we start using the updated classification in places that don't have molecular testing?
Yeah, so it's a really good question. There's two parts to it, I guess. The first one, the obvious one, was to say, well, if we can look at MSI and colorectal cancer, you just feed it endometrial cancers and it's going to give you their mismatch repair status. Easy. It doesn't translate that easily. We're doing it in the lab at the moment, but it works to a degree. So I think it's an issue of number of cases that need to be there for training it. Can we use it now for looking at MSI testing in resource poor settings? Absolutely. No reason why not. And these things are not particularly expensive. A lot of the analysis, is cloud-based. You can have on-premise testing, but it can be a cloud-based platform.
Yeah.
And I know certainly on the basis of the health economics that we were doing at Leeds to try and assess whether this has got legs or not in terms of testing. Well, it's going to cost us, say, I'm making this up, 150 quid to get our MSI testing done. I'm sure these guys want to make money, but maybe they'll charge £50 and for replacing and giving us a faster turnaround time. I've also realized that I've completely bypassed your question and answered what I wanted to answer rather than what you asked me, which was about poly testing. And the answer is yes, it's possible to have, and we've done this in breast, to have an algorithm which will give you a classifier that isn't a two-way classifier. So it's not, this is HER2 amplified or not in a breast cancer, for instance. So you can get multiple outputs still based on a single image analysis. So you could get the full spectrum, P53, mismatch repair, poly from a single image. What you have to do at that point is be prepared to give it very large numbers of cases for training purposes, in a reasonably balanced format if you've got any fighting chance of being able to get something that robust that comes out of it. And that's the difficulty still, is finding cohorts that are large enough to be able to develop these algorithms.
Yeah, but it seems that sample size is the main limiter, but that will probably change. And I suppose high quality images.
Yeah.
Are there any questions from the audience? We don't. Yeah. Do you? So Ursin says, do you routinely use P10 immunohistochemistry?
We don't tend to. No.
No. Okay. Any reasons why not?
We tend to rely on some of the other markers, to be perfectly honest.
Okay, that's your answer, Ursin. Rely on the other markers that were in that slide. So this hope it's okay, Nick. But we record these and they are sent out to all the recording sent out to all the delegates afterwards, so they'll be able to review the material afterwards as well. Are there any other questions? No? In that case, thank you very much, Nick, for your time. I learnt an awful lot there. The one that was serous because of P16, I thought it looked endometrioid. So I obviously, I'd got it wrong, but Ursine got it right. So thank you everyone for your attention. Thank you, Nick, for an excellent talk. Hopefully we can have you back again, maybe in a year's time,
Sure.
if I'm not too presumptive. I'm already starting to look for people for next year, so I'll send you an email together with a thank you note to you. Next week it's back to me doing HemePath, everyone, and the following week it's Dr. David Dorwood from Edinburgh, who's talking on lung pathology, particularly molecular testing actually in lung pathology. So please share the link with any of your colleagues as widely as possible, and look forward to seeing you all next week. Thank you very much, Nick.
No, and
Okay.
it's a pleasure to virtually meet everyone. So thank you very
Yeah.
much.